auscultation of the lungs, including all knowledge about auscultation, and additional research method which you need. Next point of the questioning, after physical examination, will continue about laboratory diagnostics, including general clinical diagnostics, clinical analysis of the blood, general analysis of the blood, urine analysis, analysis of the bronchial secretion, pleural fluid if you need it, pleural fluid which can be situated between two pleural sheets. Next type, bacteriological, virological, immunological, allergological, genetic type of clinical knowledges, morphological, cytochemical, and endoscopic type of instrumental diagnostics. So all these additional types of diagnostics included laboratory and instrumental diagnostics, and usually will start from the simple methods till the hard methods and more expensive methods. It's usually practice in all countries. And look, always I will tell you that all fluid, all contains all secrets which you can put out from your patient and you can take out to analysis. You can do it with the substance, anything. Bacteriological examination of the blood, serological examination of the blood, serological analysis, immunological analysis. The same type of analysis you can do with pleural fluid, which you can put out from the chest. The same bacteriological, allergological, immunological, all fluid and all examples of all tissues which you can put out and take out for analysis, you should do it for better diagnostic value. Next type of instrumental methods, fibrobronchoscopy. We will have some special lecture about method of diagnostics in pulmonology. Next, radiological methods, including computer tomography of the lungs, MRI, ultrasound method of diagnostic of the lungs, echocardiography, and abdominal ultrasound, and also ultrasound of the lungs, like a gold standard at real time in good developed economic countries. Not radiography, ultrasound of the lungs is a gold standard of assessment condition of the lungs. Next, radioisotope or lung scan methods for the functional diagnosis of disease of the external respiratory system, like a spirometry, like a spirography, like a pneumoscopy, like a pneumotachymetry, like a ECG, and other. Sometimes development the pulmonary heart, and we can put this diagnosis only to took one of you to ECG, like a routine diagnostic method. So it's the list, not full, but it's the primary list of inspection methods in pulmonology in patients with respiratory disease. Just I want to switch, not my voice, I just want to switch all voices. Just a minute. So continue. Before we starting discussing the main complaints and the main moments in patients with respiratory disease, I suggest you to remind some information about the structure of the bronchial tree. In some literature, you can find information about alveolar tree. Yeah, look, it's the same structure of the bronchial tree or alveolar tree. And you know already that the bronchial tree consists from the upper part and from the lower part of the bronchial tree. So the entry and the start of the bronchial tree started in the mouth cavity, and also you knew already that mouth cavity and combined and unit cavities which started digestive and respiratory system of bronchial tree, and by which close the relationship we can explain some pathological process, some pathological mechanism to develop pneumonia, for example. So then larynx, after that, after larynx continue into the trachea, and average duration of the trachea from the 10 till the 12 centimeters. After the trachea, in the level of the thief thoracis vertebra divided into two main bronchus, right bronchus and left bronchus. Also, you have to know this information that right bronchus more shorter and diameter or radius inside the right bronchus more than left bronchus, and also this pathological, not pathological dividing, but we can explain by the structure of the tree some pathological process that more often inflammation process, and like a pneumonia, we will determine exactly inside the right lungs, exactly by this situation, because the structure, the right bronchus more shorter, more thinner by the 1.5 centimeters about the left bronchus in the global radius, and also the position of the right bronchus more vertical, so more easy to go in some particulars. Then, after dividing trachea by two main bronchus, left and right, then separately by the secondary type of bronchus, then the third level, then the fourth, until the last appointed bronchioles, and in the distal parts of bronchioles, usually look to this picture. Look to this picture, its place for its place of localization, like a bulb, like an alveolus on the distal part on each bronchioles. About bloody supply of alveolus. The first alveolus, looking like cavities, small cavities like small cysts, normally structure of the alveolus. The second one type of alveolus ducts and alveolus cavity. About blood supply by the pulmonary arteries, it was not a mistake, because by the pulmonary artery go then the venous type of blood. About the pulmonary congestion, exactly between the alveolus walls and the space into the cavity and interstitium between, its place for localization of membrane, and is a location for proceeded process of oxygenation of the blood. After oxygenation of the blood by the pulmonary veins coming out and going out of the artery blood. So after oxygenation, after restoring type of oxygen. So by the pulmonary artery, the venous type of blood, some deoxygenated with decreased level of oxygenated hemoglobin, and after oxygenation process in the alveoli, because in the alveolar cavity, it's place of proceeded oxygenation process, and then coming out by the pulmonary veins, oxygenated, infected was it will be artery blood when goes by the pulmonary veins. It's some special features. So about the structure of the bronchial tree. Next point of our repeating, it will be information about mucociliary screens. like a main protect mechanism for development and for protrusion, infection obstacles or infection agents. About mucociliary recurrence, and look, consists of bronchial wall of epithelium. Yes, just a minute again. Look, bronchial wall. Yes, epithelium inside the bronchi, the lumen of the bronchi, the same type of bronchial wall in front, yeah, the same of epithelium, for example. Next, look, soil layer and gel layer, yeah. Soil layer consists exactly of the cilia, the small cilia, yeah, and the normality of this layer, its movements, and the normal direct of these movements to putting out, to go out different external agents, yeah, external obstacles. Next, above the lower of the cilia, it's place for gale lower, yeah, gale lower, which the main gale lower consists of the main structure, consists and intact gale lower is the main protect mechanism from the damaging of the cilia and damaging of the bronchial wall before remodulation. Yeah, so these foreign particles, yeah, like allergens agents, like infected agents, pushing out the gel lower, and by the movements of the ciliary to pushing out it, going outside. Yeah, it's normally, and it's the main protect mechanism for protrusion, infection, allergy agents, and from disorganization the wall of the bronchus. Okay, continue. So, structure of the bronchial tree, structure of the mucociliary clearance, and then we'll continue about complaints, the patient with respiratory disease, the main complaints. We have to know with you the main list of complaints. Sometimes it will be specific and significant complaints for respiratory diseases, sometimes not, yeah? Yes, but you have to find the list, the sequences of these complaints in your mind before starting to speaking with patient. And first, and the main complaints of the patient with respiratory diseases, it's a cough or toothes. About cough occurs as a result of irritation of the cough receptors of the trachea, bronchi, and pleura. And remind about receptors, yes. There are no cough receptors in the lung tissue. There are no nociceptors in the lung tissue. Therefore, isolated damage of the lung tissue is not accompanied by the appearance of this symptom. So, damaging exactly isolated of the lung tissue cannot be accompanied with a cough because no cough receptors in the exactly in the lung tissue. So many lung diseases are accompanied by coughing at this time. This is due to the movement of the pathological secretion which formed in the lung tissue into the draining bronchus, the syndrome of inflammatory infiltration and destruction of the lungs, and in the during environment of the pleura in case of pleurisy with focal and lobar pneumonia, in case of environment of the pleura in case of lung cancer, environment of the pleura in case of tuberculosis, environment of the pleura in case of abscesses and perithistic lung cysts. So many diseases can be accompanied by coughing, and coughing can be first and the main complaint of the patient with respiratory diseases. It's impossible to imagine the patient with respiratory diseases without coughing. For example, patient without coughing in case of pneumonia. So, the main causes of coughing of patient. First, effects on the cough and bronchial receptors of products of immune and allergic inflammation. First point, immune and allergic inflammation. Next, bacterial, fungal, and viral infection. Next, allergens of exogenous and endogenous origin, different types, and can be from external or from environment, and can be outside the origin of allergens. Toxic, thermal, or chemical effects. A cause of cough can be congenital and acquired functional insufficiency of the beta receptor separators of the bronchi, or some imbalance in the function of the beta innervation of the bronchus, like a smooth muscles innervation. Next, venosus congestion in the pulmonary circulation with left ventricular and left atrial insufficiency, and inflammatory, reactive, and malignant process in the pleura, and there is about their etiology. Please, all students, check your voice, and please switch off your microphone. So the main causes of coughing. It can be possible that will be present the different mechanism of developing this coughing. But all from this list reasons can be a cause of developing coughing. For example, developing cough in case of bacterial, fungal, and viral infection, and developing coughing in case of venosus congestion of the pulmonary circulation. Different mechanism, but the same sign. So cough, like a main complaint of the patient with respiratory disease, and then the main causes of the coughing. Continue. The mechanism of cough formation. Coughing, in fact, we can determine like a complex reflex act in which irritation of the peripheral receptors is transmitted through the branches of the vagus and upper throat nerve to the cough center located in the medulla oblongata. From there, excitation pulses arrive to the intercostal muscles, to the diaphragm, to the motor muscles of the larynx and smooth muscles of the trachea and large bronchi. Contraction released by a cough pouch. So a cough impulse is a deep convulsive breath, which followed by a sudden and intensified exhalation with a northern glottis, which accompanied by a sharp increase in air velocity and a significant increase in pressure in the trachea and bronchi. It's the main pathophysiological mechanism of cough formation. First of all point, it's a complex cough and it's a complex reflex. First point, from the irritation of the peripheral receptors and transmitted through the branches of the vagus and upper throat nerve to the cough central, which normally localized and exactly there, always localized in the medulla oblongata, like in other centers of activity. From central and the medulla oblongata, exhalation pulses arrival to the intercostal muscles, to the diaphragm, like a down level, then the motor muscles of the pharynx and move muscles of the trachea and larynx bronchi, and after that contraction released by cough pouch. Cough is one of the protection mechanisms on the same level with the presence of the healthy tissue of mucociliary recurrence. Next, the cough is the one of the protection mechanisms that helps to clear the cavity of the trachea, the lumen of the bronchi from pathological secretion and some foreign particles. Under certain conditions, it can play sometimes a negative role. The appearance of a rather intensive paroxysmal cough in which the airflow rate increases sharply. This leads to mechanical damaging of the ciliated epithelium, damaging of such structure like a mucociliary clearance, and it's growing. It can be provoked its metaplasia into stratified squamosas. At the same time, there is a progressive decrease in the drainage or cleaning function of the bronchial tree. So sometimes, unfortunately, yes, cough is one of the most important protection mechanism, yeah, to release, to protect the lumen of the bronchi and trachea from the foreign particles. But in some cases, it can be damaging and in fact increase level of the coughing by many reasons. Unproductive cough maybe can be a cause of damaging of mucociliary clearance, like also the important mechanism of protection of the bronchial wall. So, in fact, it's the same scheme with mechanism of formation of the cough push. Stimulation from the larynx, trachea, bronchi, pleura, and external acoustic, some damaging, some presence particular, yeah, due to vagus nerve, to the cough centers and medulla oblongata, then differentiated by three ways: laryngeal nerve, diaphragmatic nerve, and spinal nerves go and arrivals returning impulse from the medulla oblongata. Then it goes to deep breath, goes to glottal closure, increasing intertortious pressure, and then sudden glottal opening and outward blast of air. So the mechanism of formation cough, the main protect mechanism. Next, about cough. A cough can be dry or unproductive or without sputum production, and wet or productive with sputum production. So dry, unproductive without sputum, wet, productive with sputum. Dry, non-productive cough is characteristic of viral lesion of the trachea and bronchi, dry pleurisy, dry adherence of bronchial asthma, also appears with an increase and densification of paratracheal and palabronchial lymph nodes, mediastinal tumors compression the trachea and large bronchi. Look, there is many reasons of developing cough, and maybe increase in enlargement parabronchial lymph nodes will be pressed to innervation and can be a cause of developing cough. But in this case, cough will be dry and non-productive without sputum at all. In the same time, then the dry non-productive cough can be significant for virulation of the trachea and bronchi. About the dry pleurisy, yeah, only pain syndrome without sputum, or only with dry non-productive cough. Next, a wet or productive cough is characteristic of purulent and purulent obstructive bronchitis, bronchiectasis, wet bronchial asthma, also occurs with inflammatory infiltration and destruction of the lung tissue in case of development bacterial pneumonia, in case of formation abscesses and lung gangrene, cavernosus pulmonary tuberculosis with inflamed and repeated inflammation process, in case of neoplasm of the bronchi and lungs. So the main cause of presence that productive cough will be purulent and purulent obstructive type of diseases like a pneumonia, bacterial, in first stage is viral pneumonia, in the next stage unit with bacterial pneumonia, abscesses, lung gangrene, and so on and so on. So dry non-productive cough, wet productive cough with sputum. The duration of coughing can be constant and periodical in the form of first individual cough and tremors or coughing, only coughing push time by time. Next, short or long seizures of the cough, and a periodic cough is usually fixed in time, that it's appear in a certain time of the day. Duration coughing, characteristic coughing, mechanism of formation coughing, wet and dry, duration of coughing. Next moment about cough. And the time of early morning cough usually occurs when there is a dilation of the drainage function of the bronchial tree in patient with chronic bronchitis and bronchitis, which they need to clean it out, to put in out this fluid through the bronchi, to clean the bronchi of sputum which accumulated during the night. Yeah, because it's clear that during the night, it's normally the duration and movements of the bronchial wall of the mucociliary clearance by the activity of the negus vagus decrease. Yeah, after awakening, it's normally that cough usually occurs during the dilation and drainage function to put in out and to drainage and to clean the bronchi and the trachea. About night cough. So already a third characteristic of the cough by the time of starting, yeah, or by the timing. Early morning, next night cough is significant of patient suffering from a household form of bronchial asthma in which there is a specific sensitization of the bronchial tree to house dust allergens. At night, the patient close contact with household allergens, damp pillows, blankets, feather bed, more close the contact with allergens, and causes the appearance of bronchospasm, which is released by attack of suffocation cough with remote head from a distance with development dry wheezing, significant for patients with bronchial status or bronchial asthma. Night cough, yeah, more significant for patients with broncho-obstructive in case of bronchial asthma, about the internal allergens after contact with allergens, about the immune inflammation. Night cough also occurs with an increase in compaction of the mediastinal lymph nodes. In case of tuberculosis lymphadenitis, lymphgranulomatosis in case of enlargement of the mediastinal lymph nodes, which is associated with irritation by the reflexogenic zones of the trachea, and also it can be a cause of the pressing after irritation, can be a cause of developing cough. Next, with an increase in the tone of the parasympathetic nervous system at night, it's possible, yes, this balance between the sympathetic and parasympathetic part of nervous system, and increase in the tone of parasympathetic nervous system at night, this cause can be the appearance of the reflexes cough. And in terms of loudness and timbre, depending on the nature and localization of the pathological process, a cough can be muffled, can be quiet, and can be loud barking. Yeah, the next characteristic of the cough. So, the first one, productive or non-productive, duration of the cough, the time of starting of coughing, or the time most significant, the time of the day, which part of the day most significant for development cough, different reasons to in our mind about this coughing, and about loudness and timbre of the cough, and you can take different characteristics. Next, the main complaints of the patient with respiratory disease is sputum. Sputum from the productive rare type of coughing. So sputum is a pathological secret which formed when the trachea, bronchial tree, and lung tissue are affected in the inflammation process. Does not matter. It will be immune type of inflammation, or it will be bacterial or viral type of inflammation. In all these cases, secret inside the trachea and secret inside the bronchi, we will call like a sputum. So, causes of sputum: inflammatory and allergic edema of the mucous membrane of the trachea and bronchi. Next, inflammatory infiltration and destruction of the lung tissue. Next, allergic and infection allergies processes in the lungs, like exogenous allergic alveolitis, like eosinophilic type of pneumonia. Next cause, malignant neoplasm of the bronchi and lungs, and venosus congestion in the pulmonary circulation. So, sputum. Cow, next complaint sputum. Different cause of sputum. Inflammatory and allergic edema, infiltration, destruction of the lung tissue, allergic and infection allergic process, malignant neoplasm of the bronchi, and also venosus congestion of the pulmonary circulation. By the nature of the sputum, we can divide it by next type. Mucosous sputum is characteristic of allergic type of inflammation like a bronchial asthma, allergic alveolitis, and acute viral process, mucosous sputum. Mucosous purulent sputum, significant for bacterial and fungal infection of the bronchi and lungs. Rusty sputum appears in the initial stage of lobar pneumococcal pneumonia or only lobar pneumonia, which is associated with the presence of a large number of the hemolyzed red blood cells in it. So rusty, yeah. Sputum in the form of raspberry jelly is significant of alveolar lung cancer. Serous and serous bloody, significant for alveolar pulmonary edema. Look, also during interrogation of the patient, you'll ask about presence and cough, yeah, or maybe you can assessment this cough during you asking making cough movements. You have to ask about presence and sputum and next nature and the kind of sputum. And after taking this information, you already have some ideas about the nature and etiology of this pathological process. You can find this information only on the color and the nature of the sputum. So look to this picture, yeah. The phlegm color of the spectrum of the sputum, because some patient will tell you only about color of the sputum. Yellow and green color likely related to an infection about the purulent diseases. Pink, red, and bloody sputum could be related to an infection or cancer in some cases, and in case of presence red or bloody sputum, we need to make a quickly time. We have to find differential diagnosis and excluded neoplastic process, like more dangerous. White type of sputum, like significant or mucous, yes, for allergies, for asthma or viral infection. Charcoal or gray color of sputum, significant about changing the environment, common in people who work in coal mines and factories of heavy smokers. And brown type of sputum, significant for chronic lung disease, cystic fibrosis, or bronchiectasis. Very long duration of chronic process. Yeah, chronic lung disease, cystic fibrosis, bronchiectasis, sometimes in smokers. So different type colors significant for different pathological process, but in all these cases, it will be sputum inside the trachea and bronchus. Next, continue about the coloration of the sputum. So, colorness of whitish sputum appears about acute viral damaging, acute viral infection in the trachea or in the bronchi, about some variants of bronchial asthma and allergic alveolitis, white colorness, whitish, yes, and returning white. Next, sputum of yellow, greenish yellow, and green color with different tint of yellow and green color is characteristic of bacterial and fungal infection of the respiratory tract and lung tissue, which is due to the high contact of the neutrophilic leukocytes. So, presence in neutrophilic leukocytes, yeah, and it's a sign of presence purulent. So all sputum of yellow, greenish yellow, green color is infected purulent sputum. Yellow with a warm orange tint and sometimes a greenish tint. Sputum with bronchial asthma and allergic alveolitis may have by due to the presence of a large number of the eosinophiles. In case of bronchial asthma, it's more significant. Sputum becomes red when the admixture remains enlarged, brown or brownish, hemolyzed type of blood. Next, important features of the sputum, it's the smell of the sputum. Unfortunately, sometimes the patient will tell us about the non-unpleasant smell. Sometimes you can feel in the smell can be outside or can be in front of your patient, so you can ascertain by yourself the smell of sputum. Usually, sputum is odorless. An unpleasant, putrescent odor appears during the destruction of the lung tissue and bronchi, involved the staphylococcal pneumonia, abscess and gangrene of the lungs and bronchiectasis. The daily amount of the sputum, daily amount, daily output during the coughing, depends actually from the nature and severity of the pathological process. For example, a small amount of sputum, several millimeters per day, is excreted during a virulent. Please switch off your microphone. A small amount of sputum, about several millimeters per day, excreted, and more significant for patients with virulent infection. For example, focal pneumonia in the initial stage of corpus pneumonia and a very large amount, sometimes up to 2 liters per day, with bacterial destruction of the lungs in case of development abscesses. Different amount during the day, from some millimeters till 2 liters, 2 liters of the sputum in case of formation of abscesses of the lungs, or abscess of the lungs. So color of the sputum and smell of the sputum and amount during the day of the sputum. Continue. In case of an admixture of the blood to sputum, can be in the form of hemoptysis and pulmonary hemorrhage. And it will be some different situation. If the daily amount of the blood released does not exceed 10 and 15 millimeters, blood released in the sputum not more than 10 and 15 millimeters, then this is regarded like a hemoptysis. The release of more blood, we can assessment it like a sign of bleeding. With pulmonary hemorrhage, oxygenated blood is released from the respiratory tract, sometimes with air bubbles, in case of stagnation. Yes. Several causes are known that cause of development hemoptysis and pulmonary hemorrhage. And which causes? Violation of the integrity of the vascular wall during destructive process in the lungs tissue and bronchi, rupture of microangioms in Rand-Osler disease, formation microangioms and developing microangioms in lung tissue. We can call like such pathological disease like a Rand-Osler disease. Increased permeability of the vascular wall with viral and bacterial damage to the mucous membrane of the trachea, bronchi, and lung tissue, about the toxic, chemical, and thermal effects. Increased permeability of the vascular wall with the viral and bacterial damaging of the mucous membrane. Increased permeability of the vascular wall with systemic and isolated pulmonary vasculitis of various origin. In case the same pathological sign, but different reasons. Increased permeability of the vascular wall with venosus and arterial hypertension of the pulmonary circulation. is evaluation of the rheological properties of the blood with the definition of coagulation factors. In case of development thrombocytopenia or decrease in the levels of the thrombocytes, and an other dose of anticoagulants, perioral anticoagulants. It's also can be a cause of developing pulmonary hemorrhage. So not forget that hemoptysis, this amounting of the blood will not exceed 10 and 50 millimeter, 10 till 50 millimeters. In other cases, we can assessment it like a bleeding. Yeah, it's very important because chronic bleeding more than 50 millimeters per day. In case, in fact, and pulmonary hemoptysis and less than 50 millimeters per day can be cause of developing a chronic seizure-epidemic syndrome and chronic anemia, like a post-bleeding or post-hemorrhagic anemia. So the main causes of hemoptysis and pulmonary hemorrhage. Continue. Next complaints of the patient with respiratory disease, it's chest pain. The main cause of this symptom is irritation of the pain or nociceptors of the pleura and the proximal trachea. Because we discussed with you that no nociceptors in the lung tissue. So irritation from the nociceptors which are located in the pleural sheaths, yes, and the proximal trachea. So cause of the pain. Inflammation of the pleural sheaths. In case of adhesive pleurisy of various etiologies, including tuberculosis, parapneumonic pleurisy with lobar and focal pneumonia, and pulmonary infection. All causes of development are inflammation between the pleural sheaths and after irritation to nociceptors. Next, spontaneous and traumatic pneumothorax and hemathorax. Pneumothorax is a pathological process when including air inside the chest, and hemathorax including blood inside the chest by many reasons. But the main, it's just a crunch of the ribs with damaging of the lung tissue. Crunch of the rib damaging and putting to the lung tissue, yeah, carry out damaging of the arterioles, so it's a reason of development bleeding. Bleeding, it's a reason of development presence such fluid like blood inside the chest. So crunch of the ribs can be, and in fact it's the most important cause of developing hemathorax. Next cause of pain, primary and metastatic pleural cancer, periconcrotic pleurisy or paraneoplastic pleurisy in primary and bronchogenic lung cancer, acute viral tracheitis with high level unproductive coughing, thermal, mechanical, and toxic damage of the proximal trachea. So thermal, mechanical, and toxic damaging of the proximal trachea with damaging of the structure of the wall of trachea. Also, we have to pay our attention to the relationship of the pain with breathing and coughing, the position of the patient in bed during our examination. And increasing the volume of respiratory execution during hyperventilation, during coughing, as well as in the position on the healthy side, leads to an increase in the intensity of the pain when the pleura is affected, which forced patient to switch to superficial gentle breathing and to take a forced position. Yeah, and look, we discussed with you first position the patient with first of all bronchial asthma like a bronchoobstructive syndrome, and then position the patient with unilateral lung disease and position with a dry pleurisy. Let's remind this. In case of acute viral tracheobronchitis, especially with its hemorrhagic forms. The appearance of quite intense pain along the trachea, along the projection of the trachea, which aggravated by coughing and forced breathing, which is usually observed with lesion of the deep layers of the mucous membrane of the trachea and its mucosal layer. So during our speaking of the patient, we have to pay attention to the relationship pain syndrome with the breathing process and with the coughing. Also, after analyze this information, we can take some mind about the etiology of this process. Yeah, different relationship between the pain and coughing. And look, yes, we continue about this about development pain syndrome in case of involved pleural sheath and the inflammation process. Look, this normal structure, yeah, this lung tissue. There's some distance between the pleural sheaths, internal and lung tissue and external type of pleural sheath. So, yeah, it's normally zone of pleura. In case of inflamed pleura, in this distance, exactly small area, small distance between the pleura and the healthy lung tissue, yeah, inflamed yellow-green in case it's a purulent substance. Production of this purulent substance increasing pressure to the lung tissue from the one side, yeah, but there is no nociceptors at all. But look, increasing environment, increasing in the volume of this purulent substance start to press to the pleura. And the main localization of the nociceptors at place of pleura, surely this irritation can provoke and develop the pain syndrome. Continue. Next compliance the patient with respiratory diseases, it's suffocation or dyspnea. About suffocation, attacks result from a spasm of smooth muscles of the bronchi of various calibers due to activation of the bronchoconstrictor receptors, ephedrine or cholinergic receptors, and or a decrease in the activity of the bronchodilating receptors, beta-adrenergic receptors. So, in fact, in case of spasm of smooth muscles, it's developing this balance between the innervation of the smooth muscles of the bronchus. Because there is two levels of the innervation, yes, cholinergic energetics and alpha and beta adrenergic innervation. The main causes of asthma attacks. First of all, exogenous factors, exogenous allergens, the first and the most important, pollen of the flowering plants, house dust, animal hair, some fluff, fever, mold fungi, dried insect teaching color, house tick, dry food for aquarium fish and the meal for fish, like the very important allergens. All air pollutants like industrial dust, smoking, like active and passive smoking, earthen dust, cold exposure, cold weather outside can be external type of allergens and viral infection also. So first group is its exogenous factors, exogenous allergens. Another group is endogenous factors, mediators of immune and allergic inflammation inside the patient, biologically active amines, histamine, serotonin, bradykinin, slow-acting substance of anaphylaxis and leukotrienes, different type of inflammation mediators or some substance which can consider it, which containing an inflammation reaction. Next, endogenous allergens like bacterial and parasitics allergens, neurotransmitters like acetylcholine and catecholamines. Next, local obstruction of the branches of the bronchial tree by a tumor or foreign body when developing like a reflex bronchospasm can be a cause of developing suffocation. And venosus hypertension of the pulmonary circulation in the acute and chronic heart failure. Maybe it's not the most popular, yeah, but it's the most important, one of the most important cause of development suffocation. So, causes of asthmatic like a suffocation or like a dyspnea. In fact, suffocation is also dyspnea. Yeah, and it's a scheme of the cause of development asthmatic, and we discussed with you that asthmatic it's also a bronch obstructive syndrome. Yeah, in the central part it's human, it's a child, yeah, but it can be adult patient. So exercises and activities. Look in the upper part of the surround. Pets, yes, and all productive from the animals, meals for animals, and so on and so on. Some pollens, for any patient, it will be different pollens. Next, insects in the home, yeah, chemical fumers, like a shampoo, like a special devices of laundry, cold air, like a provoke factor for development bronchial attack. Smoking, active and passive, not forget about damaging of the passive smoking. Environment pollution and psycho-emotional stress. It's the main cause and it's the main agents which can provoke the asthma attack or suffocation or development the attack of dyspnea or attack of suffocation. So, continue. There are typical and atypical asthma attacks, if we can divide it by the nature. So, about a typical asthma attack is characterized by difficulty and lengthening of the exhalation with the development of the dry breathing, audible at a distance, and we can hear it by a distance, the smooth breathing of our patient, and we can call the distance breathing, with a severe attack of suffocation due to total bronchospasm, to total distal bronchospasm, there is a significant difficulty not only exhalation but also inspiration. It's a typical asthma attack, difficulty and lengthening of the phase of exhalation and difficulty to exhale a volume of the air from the bronchial tree, which combined with development of the dry breathing, which we can hear by the distance, and also we can detect it during our auscultation above all faces of the legs and all projection of the legs. So a typical attack is suffocation. Of suffocation include the paroxysmal type of cough, which are accompanied by shortness of breath or like dyspnea and wheezing in the chest and episodes of difficulty breathing that occur at the moment of contact with a specific allergens and exposure to non-specific factors like a cold air, like a pungent odors, like a transitional and psycho-emotional stress, returning, yes, to all these provoke factors or some activities. So typical and atypical. Only paroxysmal coughing, yes, without increasing duration on the phase of exhalation, without present some like abstention on the bronchial tree, with the possibility to make an exhale and all volume of the air, but episodes of difficulty breathing that occur exactly at the moment of contact with allergy, any type of allergen, and returning to this picture. It can be a cold air. Some patient will tell you that coming out from the home, contact with the cold air, and in this case, start of development as paroxysmal episodes of suffocation. It's also a reason of developing bronch obstruction syndrome in the base of asthma attack. Next, the frequency of asthma attacks, their duration and intensity depends on the severity of the bronchospastic or broncho-obstructive syndrome and the severity of the hyperactivity of the bronchial tree. It's clear, yeah, that frequency, duration depends exactly from which kind of bronchospasm we can identify right now. Severe, prolonged and frequent attack of suffocation usually occur with severe bronchial asthma. The time of occurrence of asthma attacks has a certain diagnostic layer. For example, night attacks of suffocation occur with the household patient of bronchial asthma. Night, remind, sleep on the pillow and contact too closely with allergens. Next, pollen asthma is characterized by the occurrence of asthma attack mainly during the daytime, while the patient is on the open air or contact with the environment, especially on sunny, windy days when the concentration of exogenous allergens in the air and then in plant pollens increase significantly. Yes, sunny, windy days, windy putting out these allergens, and if our patient staying on the outside, contact more close of this exogenous allergens. Look at this picture. Dyspnea in the pathology of the bronchopulmonary apparatus or bronchopulmonary structure is a manifestation of ventilation and respiratory failure. But with ventilation deficiency, dyspnea occurs due to the relation of the mechanics of the respiration. In case of respiratory failure, it's a compensatory reaction aimed at reducing the severity of gas exchange disorders. So ventilation deficiency or ventilation failure due to a violation of the mechanics of the respiration. About respiratory failure is a compensatory reaction which in the base of this process reducing the severity of gas exchange disorders. And look to this position. It's first position, the patient with broncho-obstructive syndrome or atypical bronchial asthma. Yes, we discussed it with you that the patient put his head on the edge of the bed and tried to help yourself to including in the respiratory process additional respiratory muscles like a major pectoralis, like a sternocleidomastoideus, and like an intercostal muscle from the both sides. First position, the patient with suffocation. In case it's suffocation. So, next complaints of the patient is development of the peripheral edema. Is a consequence of right ventricular failure and a sign of progressive development of the right ventricular failure, which develops in acute, subacute, and chronic pulmonary heart in patients with acute and chronic respiratory pathology, because pulmonary heart, it's a result of pulmonary pathology. So, and the main cause of pulmonary heart formation. First group, it's obstructive process about the obstructive pulmonary emphysema with obstructive bronchitis and bronchial asthma, about primary pulmonary emphysema with the deficiency of the alpha-1 antitrypsin. Next group, it's a restrictive process, lung compaction syndrome, post-resection condition after the surgery intervention, congenital lung pathology, abdominal syndrome, obstructive and compression atelectasis, accumulation of fluid or air in the pleural cavity, and gross chest deformities. So peripheral edema, in case it's not significant for patients with respiratory diseases, but development of peripheral edema can be, and it will be, development of the right ventricular failure. Yes, and the reason and the cause of development of right ventricular failure in the base of this process, the main development of the chronic pulmonary heart with stagnation and the small round of circulation, small cycle of circulation. So just a minute, I'll check pulmonary heart formation. So I suggest you to finish for today, and next lecture will start from the mechanism of development pulmonary heart formation and development pathophysiology and pathoanatomy of such the main process in developing the stagnation and the small cycle of circulation. Look, is it clear about all compliance, all mechanism of development, compliance, the main compliance, the patient with respiratory diseases? All is clear for you?